Hello, everyone. My name is Dr. Albert Heuer. I'm a professor at Rutgers University. I am an adjunct faculty at the County College of Morris in North Central New Jersey's Respiratory Therapy program. I'm a co-editor of Egan's Fundamentals of Respiratory Care textbook, as well as two other textbooks. However, I'm coming to you today in another capacity. I am co-owner with Terry Shenfield of A&T Lectures, and today I will bring to you a presentation entitled The Fundamentals of Assisting and Performing Intubation. During this presentation, we'll focus on several learning objectives. Among them are that we're going to review the guidelines for both intubation and assisting others in doing this procedure. We'll review the indications and contraindications for intubation. We'll examine special considerations for managing a difficult airway. Very, very important topic, because when you encounter a difficult airway and the patient needs an artificial airway, time is of the essence, and understanding these special considerations is extraordinarily important. We'll also review related equipment. We'll examine laryngoscopes, the contents of a typical intubation box. We'll also talk a bit about sizing endotracheal tubes, as well as laryngeal mask airways, or LMAs. We'll then focus on key steps in the actual procedures, confirm placement, very, very important. We'll examine documentation, and probably most importantly, we'll examine references related to this topic for those of you who may wish to drill down and learn more about it. So let's take a look at the guidelines. For those of you who work at a facility or within an organization where the respiratory therapist is included in the ensemble of clinicians who intubate, the most experienced intubator should be the one doing the procedure. For example, if you work at a teaching hospital where you have resident physicians who are learning how to intubate, and you encounter a patient who appears to be a difficult intubation. They're having trouble getting sedated adequately, they have odd anatomy, etc. In general, the most experienced intubator should intubate. And if that happens to be a respiratory therapist who has 25 years of experience intubating, including recognizing and encountering and dealing with difficult airways, that should be the person who intubates. The obvious exception is that if you're encountering a case where it's a facial trauma, where it looks like a very, very difficult case, we should always defer to anesthesia. The problem is, if you work at a small or mid-sized hospital, and it perhaps is the weekend or a holiday, and there's one anesthesiologist who maybe is on call, in an emergent situation, that anesthesiologist may not get there in time. So you should, again, defer back to the most experienced intubator should intubate. Where, and we're really not talking about the overall setting, home care versus acute care hospitals, but that does matter. So when I did home care many years ago, intubation was really a non-issue. There are some long-term acute care facilities, or LTACs, where respiratory therapists intubate, okay? But the setting I'm really focusing on is within hospitals, within tertiary care or acute care hospitals, where the respiratory therapist is a primary intubator. Okay, that can occur on most floors and in many ICUs. However, in other settings, such as the emergency room or certainly the OR, okay, the operating room, generally it's an anesthesiologist If it's not the OR, maybe the ER or ED, emergency room or emergency department, it may be the actual intensivist or the attending physician who's in the emergency room who may be doing the intubation. The question also comes up as to how much medication that the patient can be given and still have the respiratory therapist do the intubation. That too varies. In some institutions, they'll actually have a maximum of, let's say, 5 milligrams of Versed or 10 milligrams of Versed. I will tell you, the other day I assisted one of my colleagues in intubation, and this particular patient appeared to have a tolerance, being strictly intubated for an endoscopy procedure. And I will tell you, it took a lot to get this guy down so that the therapist could actually intubate. We were kind of on the cusp of calling anesthesia. We gave a little bit more. We didn't give it, but the attending physician who was there basically advised the nurse who was giving the IV medications to give more medication, and the patient had a blood pressure that could tolerate it. And at that point, we were able to actually get the tube in. But you should use discretion. If the patient is still thrashing, particularly if they're given a lot of medication. So a lot of these the medications such as Versed will have a depressant effect on not just the central nervous system, but also blood pressure. So also some elements of the autonomic nervous system. In that case where more medication really can't be given, then it's probably best to defer to anesthesia. Now let's examine some of the common indications and contraindications. So whether you work within an organization where respiratory intubates or not, many of you or all of you are really probably familiar with some of these indications. So it may be either you're the one who's getting ready to either do the intubation or assist with the intubation, or you're the one who's advising the nurse to call anesthesia. So those indications would be hypoxemic and or hypercapnic respiratory failure. So whether it's actually happening or it looks like it's on the cusp of happening, if the patient has low blood oxygen, particularly if it's occurring abruptly. So we're not talking about a COPD patient who has chronic mild hypoxemia. We're talking about somebody whose saturation has gone from 95 to like 75 in a relatively short span of time, and it looks like the reading is very accurate. Or maybe it's a neuromuscular patient or a drug overdose patient where it looks like they're in hypercapnic respiratory failure. In the case of a neuromuscular disorder, you can give all the Narcan you want, as you would with a narcotic overdose, but that Narcan is going to do nothing for a neuromuscular patient, in which case they probably need to be intubated. We can certainly consider other options that have come in our arsenal, such as non-invasive ventilation for a patient who's in hypercapnic failure, or a high flow nasal cannula for a patient who's in hypoxemic respiratory failure. But ultimately, if the patient can't tolerate those devices, or frankly, they're just not working over a period of time, or they're required, the BiPAP is required for days on end, then the decision really, probably should be made to intubate the patient. Prohibitive breathing pattern, so prolonged tachypnea, and if it looks like that tachypnea or prolonged shortness of breath is not related to anxiety, it's not related to pain, something that's not really a respiratory etiology, but it's something that we as a team, the physicians, nurses, and RTs can help fix. But if that prohibitive breathing pattern is not due to, again, anxiety or pain, then the patient may simply need to be intubated because they're not going to be able to keep that tachypnic respiratory pattern up. Inability to protect the airway. So there's a saying as far as Glasgow Coma Scale, when the Glasgow Coma Scale is 8 in parentheses or less, intubate. So it's so if the patient's neurostatus is such that they're obtunded, or they're seizing for a protracted period of time, or there's some other issue with airway protection, they're in end stage, some sort of a neuromuscular disorder, they may need to be intubated strictly to protect the airway. Severe and worsening respiratory muscle weakness, as you again can see with some of your neuromuscular disorders, whether it's a rapid onset such as you might see with Guillain-Barré, or a more mild onset, but that worsens and continues. that you might see with like muscular dystrophy, it may be necessary to intubate the patient. Some of the contraindications, and I say some of the major contraindications, would include presence of a DNI, do not intubate order, laryngectomy, because if you recall, with a laryngectomy, indeed you have a stoma, in the neck, but there is no patency between that stoma, the actual trach, and the upper airway, because the patient has had a laryngectomy. Epiglottitis, and I included epiglottitis here. The patient may need to be intubated, but you have to be very, very careful because probably a lot of that tissue that's around the glottis. That's why it's called epiglottitis, because you have a swelling, irritation, probably an infection of the epiglottis and the tissue around it, and you may well have a patency. You certainly hope you do, but it may be very, very small. And if the patient has a laryngospasm, let's say you have a newer or less experienced intubator, and they start kind of poking around down there, and you have a laryngospasm, you just lost your airway, now you have a medical emergency. So in the main, or in general, if a patient has epiglottitis, then it should be done by an anesthesiologist, and preferably in an OR-like setting. So the OR, or in an area within the emergency room where surgery can be done, an emergent tray can be done. Tachypnea due to pain and anxiety. So I alluded to that just a little bit in the beginning part of the slide, where the tachypnea is not due to a respiratory etiology and perhaps can be fixed. The patient can be given pain medication, anxiolytics. They can be, if it's anxiety, spoken to in a calm way to try to kind of ease their anxiety, that sort of thing. Let's not intubate those patients. Very important topic is recognizing a difficult airway. So in the next slide, I'll talk about what a Mallampati score is. But if the patient has a high Mallampati score, so the higher the score would be associated with a difficult airway, low score, less difficult or relatively easy airway. Reported history of difficult intubation would be something relevant as well. History of multiple intubations and or tracheostomies. So with tracheostomies, you may actually have some scar tissue. So the tube, you may be able to visualize the glottis fairly easily, but the tube will go to the glottis, maybe start to go through it, and then that scar tissue that's distal to it may be problematic. So just be aware of that as well. Chest X-ray, neck X-ray, really examination. And I have a couple of examples that I'll show you as well, where you look at, tortuous just means that it's irregular trachea. A narrowing of the upper airway or trachea is also another thing that should be examined. Ability to adequately sedate the patient or not. And you'll find that some patients that have their substance abusers, whether it's alcohol or other substances, they'll tend to have a tolerance and be difficult to be able to sedate. Upper airway trauma or surgery is another consideration where you may expect or have a higher likelihood that the airway may be more difficult. So the Mallampati score is one of the, if you will, measurements or scales that's used to estimate or determine the degree of difficulty with an intubation. And some anesthesiologists before surgery they'll of course meet with the patient, but they will probably assess the patient and ask them to open their mouth. And it gives them some broad idea of how difficult the intubation will be. Now, in reality, sometimes when you actually go in and with the laryngoscope, you may find that your initial evaluation is different. Perhaps you thought it was going to be easier, and you thought it was going to be a 2, and they ended up being a 3 or a 4. Okay, so let's look at the actual evaluation. It ranges from 1 to 4. With 1 being the easiest, 4 being the most difficult. Again, if the patient's conscious, meaning this is the anesthesiologist meeting with the patient, hours, a day before the procedure, open your mouth, they'll do an initial assessment. But the proof is in the pudding when the actual laryngoscope is placed in the patient's mouth, and you're actually looking. And in some cases, it's very difficult to evaluate how difficult they're going to be in advance, but then you have the laryngoscope and you're actually looking, and again, you thought they were going to be 1 score and they were actually another. So if you look at the lower, the bottom right-hand side there, where it's a class 4, it really looks like the tongue is large, certainly larger than you have with class 1. You can't see the uvula, so there's some, classic findings that you'll have But again, Mallampati is just another tool that we have in order to determine in advance and retrospectively to say, that this patient was difficult, and indeed they were difficult because they were a class 4, as well as perhaps their glottis was very anterior and difficult to visualize. Expounding a bit on the topic of difficult airway, you can, as I mentioned earlier, some chest X-rays actually will give you some good idea. Will actually include elements of the neck and the trachea. In some cases, it's just a neck X-ray. So on the left-hand side of this image, you actually see it's a bit tortuous. So you actually have, if you will, an offset trachea. So instead of the trachea where that arrow is on the left side image there, you kind of see that deviation to one side, and then it straightens out again. So that's one suggestion where the airway may be difficult. And in the one on the right hand side, you actually see a narrowing. It really looks like that may be somebody who has epiglottitis, where you're actually seeing what's called the steeple sign, and you could see that with croup. This looks like an adult, so it's probably not a perfect analogy there, but the shape of the trachea, is a kind of a steeple sign, suggesting that the tissue around that trachea, may be swelling or could be scarred. So swelling is, a temporary condition in most cases. The scarring is typically not. But in either case, the theme is that X-rays can be a potentially valuable tool if the patient's been X-rayed. If you have a recent X-ray on the patient, it's not a terrible idea in a non-emergent / elective intubation to avail yourself of this review as well of imaging. So in a few portions of this presentation, we've talked about some of the individual factors that are more closely associated with a difficult airway. However, I also wanted to mention that there are some integrated scales that are out there that look at multiple factors simultaneously in order for the clinician, the anesthesiologist, the attending physician, the respiratory therapist, to in advance look at these various factors and try to assess the degree of difficulty that they may encounter in intubating the patient. So one of these scales is known as the L. Ganzori Risk Index Scale. And it was actually named after the founder of it, who is a prominent, if you will, anesthesiologist in the country of Italy. And he and his colleagues took a look at these various factors that are associated with a difficult airway. They include mouth opening, thigh mental distance, Mallampati score, and we have talked about Mallampati score previously, neck movement, ability to actually extend, if you will, the jaw, body weight, and history of difficult intubation. So this particular scale has been studied, and it's been determined that certainly like any scale, it has some limitations, but in general, a few things can be said about it. The lower the score, the easier the anticipated intubation. And as far as cutoffs, while the founders of this particular scale were reticent to say, this is easy, this is medium, this is hard, they basically said that a higher score, that is somewhere north of 2, would tend to be associated with a more difficult airway. And as you go further north of 2, go to 4 or 5, it would be perceived as a particularly difficult potential intubation, and additional adjunctive measures such as calling anesthesia and having your supplies and medications available for a rapid sequence intubation available. In extreme cases, it may actually entail doing the intubation either with a bronchoscope or having one nearby, immediately nearby, perhaps with the bronchoscope threaded right through the endotracheal tube. And in the most extreme cases, there may actually be a trach cut-down kit to do an emergency tracheostomy in the most difficult circumstances. such as those involving situations where the airways may have been traumatized, a motor vehicle accident, industrial accident, extreme burns and fire, things along those lines. So in cases where your index of suspicion that the airway is going to be difficult is higher than normal, some of your options, some of the tools, if you will, that you have in your, figuratively speaking, toolbox are as follows. Discretion is the better part of valor, and it's typically not a bad idea to consider calling anesthesia. Using a video laryngoscope if they're available. Now, I say if they're available because in many acute care hospitals today, video laryngoscopes have become the standard. So whether it's a McGrath, whether it's a kaleidoscope, there's all different models that are out there. Even Ambu has one. They're becoming the standard. They're not a panacea. They offer some clear advantages and a few disadvantages, and I'll allude to them a little bit later on. But again, in balance, they tend to offer a, if you will, a clinical advantage. Also looking at other specialized equipment and supplies, a bougie, sometimes they're called gum bougies. So they're kind of they're actually, or endotracheal tube introducers, where they're about a little bit more narrow than coaxial cable. Okay, they're plastic or PVC. Generally they're shaped blue, but different colors that are there. They have a little angle on the end. And the idea of a bougie is that it can be introduced. It's a smaller diameter than an endotracheal tube, and it can be more readily introduced and is angled differently so as to also be more easily introduced through the glottis. And the idea is once you introduce, think of it like threading, now that you have a guide wire, not literally, but figuratively speaking, you now have a guide wire. And it's gone through the glottis, also more easy because it's more narrow than the endotracheal tube. The endotracheal tube can then be threaded over it. And it's longer than the endotracheal tube, so now you can thread it all the way over it, through the glottis, and then once you have placement visualized, and it looks like your cuff is now well through the glottis, you can then remove the gum bougie, of course, inflate your cuff of your endotracheal tube, and confirm placement via end-tidal CO2, bilateral breath sounds, and other measurements that you have at your disposal. Another wise move is using or having available smaller sized ET tubes. So if it's somebody, I'm an average size male. My ideal body weight is about 170, 175 kilograms. So the tube for me would be about an 8.0 or an 8.5. But in an emergent situation, it's not a bad idea to have, if you're using an 8, to have a 7 and a 7.5 available as well. You want to use the largest size tube that you can within reason, and I will offer you guys some additional guidance in this presentation on sizing tubes, certainly for the adult population. But you want to use, if it's a choice between a 7 and a 7.5, all else constant, for someone my size, average size male, I would absolutely go with the 7.5 if you can get it through, because at some point the tube it would be too small to actually do things like bronchoscopy, or you'd need a pediatric scope to do an adult type of deal, which also has its limitations. So but having the smaller size ET tube available, again, intubating the patient with an 8 but have a 7.5 available, would allow you, sometimes you can actually visualize the glottis, it just won't go through because it's a small glottis. The 7.5 will go through more easily. Using cricoid pressure is another strategy as well. And again, in bed, top of the bed, with a sniffing position. So also cricoid, but also positioning the patient properly can offer an advantage. If possible, leave oxygen cannula in place. So it used to be, take all the equipment off, or they have a high flow or regular nasal cannula. As long as it's not in the way, as long as it's not impeding your view in any way, then it's not a terrible idea to leave it in place, leave the oxygen flowing, and it may give you a little more time rather than having the patient desaturate quickly. It'll buy you time in that regard. If available, some hospitals and healthcare providers will have difficult airway boxes. And again, they're typically kept near the ICUs, if they're adult boxes near the adult ICUs, etc. Fiber optic equipment in extreme cases. So actually having a bronchoscope available in very specialized situations. We've actually had the bronchoscope there. We have non-disposable bronchoscopes, but about 80% of our procedures that we do in units and elsewhere in our hospital are done with disposable equipment, so disposable bronchoscopy equipment. So we have the bronchoscope there. We may actually have the endotracheal tube threaded through it in advance because we're expecting, perhaps a difficult airway, and we may not use it initially, but it's there. We'll have it at bedside, etc., and have it ready to go. More elaboration on when to call anesthesia. If the patient, remains awake or agitated despite a lot of sedation, particularly if their blood pressure starts going, or just they start to decompensate in some way, their saturations are affected, etc. Failed attempts. So if the RT or the nurse practitioner or whatever, a physician assistant, if they've tried 2 times, it's a really good idea to say, let's get anesthesia involved. The exception would I say obviously be if you work in a smaller hospital, it's the middle of the night, somebody's on call, but they're on their way in type of deal, and then just use proper discretion. If the face, neck, trauma is involved, or there's some sort of an abnormality with that, if the patient has a kyphotic neck. So whether it's a history of having kyphosis, or you take the pillow out, from under their head, and their head still stays elevated off of the bed. Generally, again, unless it's emergent, because you're not going to probably be able to achieve that sniffing position, it's a good idea to defer to anesthesia. Difficult airway, so that as discussed in the preceding slides, and I'm not picking on individuals that have Down syndrome, but they typically have more difficult airways. Their cheeks are fatter, their tongues are bigger. There may be some difficulty in having them follow commands initially, and then they can be more difficult to do. And they may have a higher Mallampati score or not. But if the patient has a high Mallampati score because of Downs or because of any other their anatomy, consider calling anesthesia, as you should if there's a report of a difficult intubation where we know that the patient required fiber optic intubation in the past. I would just have the equipment there. Maybe the decision is just to do it through fiber optic technology because their past intubation has required it. History of multiple intubations and/or tracheostomies, severe bleeding disorders where their platelets, or particularly if the platelets get normal low end of for the range for platelets is, depending upon which book you look at, is 130 to 150. But a critical level is where platelets start approaching like 50 or less. Good idea to just call anesthesia, because if you're trying to put the tube in, and if it in any way even slightly traumatic, you may end up with a bleeding, and it's not just bleeding anywhere, it's bleeding into the patient's respiratory tract. COVID-19 or highly infectious patient, in some institutions they just the intubations were done not by respiratory, even if it was a hospital where respiratory normally did a lot of the intubations during COVID-19 outbreak. Not that it's gone, but on the East Coast where Terry and I are located, we've had basically the initial surge, which was horrific, and we've had 2 spikes since then. Who knows what's going to happen in the future? But a lot of these places were just having anesthesia do it and using what's called a rapid sequence intubation, which involves sedation, paralytics, put the tube in, confirm placement, secure the tube, obviously ventilate and oxygenate the patient, and move on. A little more on related equipment, focusing on laryngoscopes. So you have traditional non-video laryngoscopes, which, by the way, many hospitals will just have in their intubation box, just there. A lot of them, even though they're made out of metal, a lot of them are disposable today. And again, more and more facilities are starting to put video scopes in their intubation boxes. And again, basically, what's found in the intubation box, either disposable or non-disposable, As far as the actual blade size, if it's an adult intubation box, they'll probably have number 3 and number 4 blades. The Macintosh blade is curved, and you guys, undoubtedly know this stuff, but just for the sake of completeness, the Miller blade is straight. Pediatric size blades would typically be 1 and 2, Macintosh and Miller. And even if it's an adult unit, so my world, quite honestly, for the past roughly 20 years, where I've worked in the adult ICU at a major medical center also in North Central New Jersey, my world is the adult world. But we always have a pediatric box intubation box in the unit, in our adult units, because sometimes you get a patient who's age, they're 25 or 35 years old, but they have some condition where they have failure to thrive, and they actually have the body habitus of, let's say, a 12-year-old, something along those lines, or their anatomy is just odd in some manner. So we always have at least one pediatric box in our adult box. We do the same thing with our emergency room. We have adult boxes, but even in the adult side of the emergency room, we still have pediatric boxes. A little more on video scopes. They need to be turned off and disinfected after each use. Critically important, the batteries. Some of them are rechargeable. A lot of them aren't. A lot of them just have batteries. Our McGraths, the model McGraths that we use, the battery is actually good for 250 minutes. There's other models that are out there. There's some that require to be plugged in, but in any case, after the use, they need to be carefully disinfected. The McGrath, the screen is attached to the handle, disposable battery, blade size slides over the distal end, clicks in place. Again, 3 and 4 blades. Blades are not interchangeable with other scopes. We used to use what's called a UE scope, and we occasionally would have newbie intubators who grabbed the wrong blade, the wrong scope, etc. Extra batteries are generally found in the case. Kaleidoscope is, screen is attached. I'll show you a photo a little later on in this presentation. A special stylet, disposable blade handle. They're expensive too, so it is. CMAC is more of a curve to it. Our anesthesiologist, they typically will show up to the units with their CMAC. And I actually had a case where the anesthesiologist, we have a great relationship with, not just with anesthesia, but with our head of anesthesia. He's a real champion of anesthesia, working closely with respiratory, and he very much wants us in the ensemble of clinicians who intubate. It actually lightens the load on his anesthesiologist and his nurse anesthetist. So they may show up to the unit with a CMAC, and I remember the anesthesiologist looked at me and said, "Hey Al, this doesn't look that difficult." So I got a chance to use a CMAC once in my life, so it was just kind of neat. It's a little weird also because with some of these with the CMAC, the actual screen is not part of the handle, so you're kind of like you're separating your dexterity from your vision type of deal. So it was took a little bit of getting used to, but it was neat to be able to try something, a new approach. A little more elaboration about video laryngoscopes. So I mentioned earlier that many of the models that will have a battery that's just replaceable, non-rechargeable. It's a good idea to check the remaining battery life for the McGrath scopes and other similar scopes periodically. So for instance, when I come into the unit, and I typically my kind of check, my mental checklist is I will just get the video laryngoscope and check to make sure that somebody didn't clean it and put it away but forget to turn it off. So you'll have a depleted battery, and it's just, you don't want to be at the head of the bed in emergent intubation and you're screwing around with replacing the battery. And it's not hard to do. They don't come off easily. So unless you know exactly how to do it, you may be pulling and say, oh, if it's this hard to take it off, it's, I'm probably doing the wrong thing. But the batteries are meant not to just pop off easily. It's just kind of this weird paradox. But in any case, checking the remaining battery life. If the distal end, so I used to use a fair amount of Surgiloop. When we use the old-fashioned traditional laryngoscopes, and the first few intubations I did with a video scope, and that was probably 7-8 years ago, is if that Surgiloop gets on the distal end, it will fog it. Okay, not literally, but it will obscure your view. So now I typically use much less Surgiloop. I use it on the distal end of the ET tube, but much more judiciously or sparingly, as I say in this presentation. And again, the cure for that, if it does happen, is you're going to unfortunately need to stop what you're doing, take the laryngoscope out. You may need to take the blade off and literally wipe it off, wipe off the lens at the end of it, and kind of repeat the procedure. Plus, there exists the possibility that people that are actually observing you will know that you haven't done too many of these before, etc. Whatever. ET tube tip will not initially be visible. So it's at some point, obviously in the beginning, it's very visible. But if you're using a directly intubating the patient using your laryngoscope, you're seeing the entire way. With most of your video laryngoscopes, at some point, you're actually the distal end of the tube. You actually can't see. You need to continue advancing, and then it'll become in view with the actual screen. Okay, so it's easier with a video laryngoscope to view the glottis, but you need to get used to the fact that there's going to be a point in the process where you're going to probably temporarily lose view, and you just need to very carefully advance the tube. May require more of a curve to the end of the ET tube. I just don't use too much of a curve myself. And what they're finding, even though I said earlier, and I repeat again today, video laryngoscopes are becoming the standard of care, but they're finding that there's more, not life-threatening, not permanent damage, but let's say minor trauma to the soft tissue than with a traditional approach. And they suspect it's because there is a point at which you're advancing the tube, but you're not directly seeing what's happening. That tube needs to come back into view in the screen. And just quickly, this is just an example of a video laryngoscope, one of the many models that's out there, where the screen is actually attached, to the laryngoscope itself. This is one where it is also a videoscope, but where you now have, it's a kaleidoscope core, just one of the examples, where you have the screen is separate from the scope. The one thing I'll mention about any of these, CMAC, kaleidoscope, or others, is the length of the cord. So from the screen, there's a cord that goes to the laryngoscope. And notice the base is your typical kind of IV pole base. For small rooms, it can be very unwieldy to try to get, we already have a couple of IV poles. You may have, some, CVVH running or not. You may have, other equipment that's in the room, again, just so in some cases you're going to need to get the actual tower with the screen close enough where the cord will reach and where you can actually see it. So it's a little more unwieldy, whereas if you have a McGrath or just a handheld device like the one in the preceding slide, it's just less onerous. So it's something to think about. Smaller screen with the other one than this one, but it's also less onerous. So you're trading, one advantage for another. So regarding more unrelated equipment, aside from laryngoscopes, aside from the actual intubation box, which is going to have multiple size endotracheal tubes, stylets, syringe for inflating the cuff, SurgiLube, suction catheters, a colorimic end-tidal CO2 identifier or adapter that's in there as well, and other similar equipment. We have LMAs in our intubation box, etc. What else do you need? Well, immediately outside the room, you have hopefully receptacle for clean PPE. People are donning it on. In many hospitals, they actually require the use of an N95, not just for the intubator, but for people near that airway that are actually assisting with it or actually doing the procedure. A age-specific manual resuscitator, or basically manual ventilator. Ambu bag is one of the manufacturers. Air mask bag unit is what Ambu stands for, by the way. Oxygen flow meters, the suction source, tubing, Yankauer, end-tidal cable and adapter, and a word or two about end-tidal. It's if you have access to waveform capnography, it's the standard of care. If you don't, use a colorimic. Difficult airway box, if the actual facility has a difficult airway box or that sort of a protocol that's in place, you'd have it not necessarily in the room, but perhaps immediately outside of the room. I say that because if it's in the room, if it's close enough to the patient, it may need to be disinfected or just tossed all together, depending upon the protocol at your organization. What I like to say is this, is that we have a program where our new hires go through intubation training. They go through a class, they go through mannequin training, and they need to do at least 3 precepted intubations. And I'm a firm believer, we don't do this, but I'm a firm believer that anybody in that program should be required to assist in at least like 3 to 5 intubations. They should be required to make sure that the room is set up. If it's not, that they're making sure they're getting the suction set up, they're getting the end tidal cable, et cetera, rather than being at the head of the bed and having people that are very experienced at doing this helping them do it. What I do is, we both set up the room together. I will actually go to the head of the bed and I take a peek. And I want the therapist that I'm precepting right next to me. And if it's a straightforward, easy intubation, I will literally just usher them in front, providing it's not emergent, the patient's not decompensating abruptly, and then just kind of guide them through the procedure, literally guide them, they have their hand on the laryngoscope with their left hand, they have the tube with their right, and I'm just guiding them in the process. That seems to work as a pretty good approach at our institution. A little more elaboration on the contents of an intubation box. So many of the hospitals and healthcare organizations have a similar approach. They have a top portion and bottom portion of the intubation box. So in the top portion, age-specific disposable laryngoscopes and handles. Those would be more the old-fashioned type, but some organizations more and more are starting to put video laryngoscopes in those as well. Multiple age-specific ET tubes. So, and I'll show you more on that in an ensuing slide. A stylet, probably 2 stylets, 10 ml syringe for inflating the cuff, etc. Subglottic suction stickers we use, our default is subglottic. If we're having difficulty in intubating with a subglottic, we'll just use a regular one. Subglottics, the actual lumen, the outside lumen of the tube is about a half a size greater. So if you're using an 8.0 with subglottic, it's probably closer to an 8.5 non-subglottic. So for difficult intubations, you may just switch over from a subglottic to a non-subglottic. Lower portion has more of your boutique stuff, your extra age-specific ET tubes, the color sensing, end tidal detector. We have a little baggie with Surgilube, saline, nipple adapters, etc. Extra stylet, suction kits, etc. So in a lot of organizations, the contents are pretty similar, with the possible exception that, again, more and more organizations are including video laryngoscopes in these boxes as well. As referred to in the preceding slide, this is just an example of sizing, if you will, your endotracheal tubes and your LMAs. So you can see at that kind of light green box there near the bottom, you actually have, for females 7.0 to 8.0, and for male 7.5 to 9. And then for other younger folks is the top portion of that green, light green slide. In the lower right hand side, the black box there actually has LMA sizes. And what we find is that some of the clinicians are less aware of the sizing of LMA. So this is it's good to kind of review this. About 2 years ago, I took the ACCS exam, the Adult Critical Care Specialty exam. And, a lot of questions on hemodynamics. So one of the things is they wanted you to know sizing of not just ET tubes, but, of trach tubes as well as LMAs, as well as many, many other kind of I'm going to say more boutique ICU content information, but LMAs were definitely on there. Insofar as actually doing the procedure, some of the major steps include the following: confirming the indication, of course, obtaining a physician's order. Initially, it may be verbal. Make sure you circle back and that the physician has actually put an order in your, a lot of it's electronic health record system, but they've actually entered it. Gather and set up the equipment, as noted in the preceding slides. Position the patient, pre-oxygenate, medicate. Mainly it would be sedation, but in some cases it may be with rapid sequence that they're actually paralyzed. Check, remove dentures, excessive secretions, insert laryngoscope, sweep the tongue to the left, lift the epiglottis to visualize the glottis. This is in a perfect world. Probably 80% of them go like this. It's probably 80% fairly routine, 10%, you got to do, and 5 or 10%, I don't want to call it terror, but, high anxiety, a high pucker factor. Insert the laryngoscope, sweep the tongue, as I said, advance the ET tube through the oral pharynx, under the epiglottis and through the glottis. Inflate the ET tube cuff, connect the manual resuscitator, ventilate, and what we do is we'll put an end tidal adapter. We just have it hooked in there, right away. The same end tidal adapter we'll use on the ventilator. We just kind of, move it, have it on the manual ventilator bag, and just so we can see our waveform. Confirm initial placement via ET tube, again, bilateral breath sounds, BBS, and eventually a chest X-ray. Now, if you're not the intubator and you're the one that's assisting, I know I shared you my thoughts on. I think that we all, we need to be proficient in the assisting part of this, whether you're in an intubation, training program or not. Really is one of the core competencies. So helping ensure that all supplies and equipment are in the room. Helping prepare the equipment, helping making sure that the suction isn't just there, that it's set up sufficiently so we can evacuate the secretions. I actually had a case where one of our trainees, and I own this, but I said to him, I was intubating, and he wasn't certified, he wasn't even in the program, and I said, so-and-so, get me a yank hour, okay? And what he did was, I was at the head of the bed getting ready to intubate, and he handed me a yank hour. It wasn't connected to anything. And my colleagues, I was just recounting it. It was fine. It was there was no yelling and screaming, just whatever. It was what it was. But I was sharing the situation with one of my colleagues, and he said to me, "Hey Al, you asked for a yank hour, he gave you a yank hour. What were you expecting?" So anyhow, so you get the idea. Preparing the equipment, inserting the stylet, connecting the syringe, so you can see what it had. I'm not going to read all this to you per se. Having available different size tubes, as I talked about, setting up the end tidal as well as the yank hour, positioning the patient. So a lot of this stuff is what you would do if you were the intubator, but now you're the person standing to the side. Maybe you will become the intubator. If you've gone through the training, you're just helping somebody else and they can't get it in and it needs to go in. Sometimes another set of eyes, that sort of thing. We've had intubations where there was two of us. One of us was laryngoscope, is a difficult situation in like an MRI setting, in a CAT scan, in the hallway, whatever the case may be. I don't want to make it sound like it's the Wild West, but in some cases you do what's prudent, you do what you need to do. Ventilating and oxygenating the patient, helping ensure that all supplies and equipment are situated properly, applying cricoid pressure, and I will show you what that looks like and talk about that in an ensuing slide if it's requested. Cricoid pressure is known as the Selleck maneuver, with an S, Selleck maneuver, like Tom Selleck. Its main purpose is to, if you will, kind of close the esophagus. Remember, does not have cartilaginous rings, is to close that off, because the trachea does have cartilaginous rings, to help prevent regurgitation. Okay, what they found is it also can be helpful in visualizing the glottis. So cricoid pressure, once the patient's intubated, inflating the cup, help confirming placement, securing the tube, manually ventilating the patient, setting up the ventilator. Lions and tigers and bears, oh my. A little bit more elaboration on the sniffing position here, and you can kind of see, so the A and B on the left hand side in the center is actually the sniffing position. All the way over on the right hand side is kind of like, okay, well, what is it doing? It's aligning if you will, the airway opening, the mouth, better aligning it, I should say, with the glottis. This slide provides a little bit of detail on actually inserting the laryngoscope. So the left-hand portion of this slide is really showing you where you're inserting and carefully avoiding the teeth. So you're inserting the laryngoscope, and then the right-hand side, B, is you're sweeping the tongue to the left, and you're actually lifting. So you're really sweeping in one direction, but you're also lifting up to help better visualize the glottis. This slide is showing you two things. Number one, the top portion there is showing you where you're positioning your index finger and the thumb to provide cricoid pressure. Okay, the top portion. The bottom is really showing you it's trying to show you the glottis before cricoid pressure, perhaps on a patient who has a very anterior glottis. And then on the right-hand portion, shown as B, when the cricoid pressure is applied, that the glottis is much easier to visualize. This image is just showing you passing the ET tube through the glottis. So you actually have the glottis shown there as A, and then B, you can actually see kind of the bottom portion of B. You can just see the actual ET tube, kind of middle upper. You can see the cuff going right through the cords and being advanced through the cords. ET tubes also have these black lines, which is meant to be a general guideline. So it's actually proximal. It's upstream from the cuff, and it's giving the intubator a basic guideline to advance the tube to about that point. Okay. Obviously, the chest X-ray may say that the tube needs to be, retracted, advanced, or whatever, but it's just to provide the intubator with a basic guideline. Confirming placement is critically important. So preliminary verification, if you will, is auscultating the lungs, hopefully, listening over the lungs, hearing breath sounds, listening over the abdomen, and not. Fogging in the endotracheal tube is generally not, it's been studied, not a good means of verification. And I've heard my colleagues say, oh, you got fogging in there, you're good. Okay, so you want to use it as a tertiary or quaternary, like something that maybe is a little helpful, okay, fine. But don't use it as your only means of confirming. As I mentioned earlier, confirmation, the gold standard is end-tidal CO2 with waveform capnography. Waveform capnography is also helpful because if you're in a resuscitative effort, it's also going to give insight on the, if you will, the quality of the resuscitative effort. Color change indicator, if waveform is not available, chest X-ray for, immediately following to confirm not just proper placement, but if it's too deep or too shallow. So I'm not going to say a lot about documentation. We mentioned earlier that you got to make sure that the physician order is documented, depending upon which electronic health record or EHR that you use. With the Epic system, it's called an LDA. It stands for line, drain, airway. So you'd go into that function and you just make sure that the endotracheal tube is entered in there, the correct size, who did it, any sort of details as well. A progress note is a good idea, and the charge. We actually charge for the procedure itself. Non-electronic health record documentation is we actually have a separate handwritten form because we track intubations. We even track unsuccessful. We track ones that we've assisted, and it's just we have a pretty robust system. And actually, my colleague of mine and myself are really looking to perhaps look at what we've done and publish a piece so that other places kind of learn from the system that we have in place for getting as many of our respiratory therapists certified and proficient in intubating. So some take-home points, or kind of summary points, if you will. Intubation is a potentially high-risk procedure. Okay, and it's high risk in many circumstances, particularly if the patient is decompensating or they've decompensated. You're at a code blue situation. So the procedure accounts for a disproportionate number of medical malpractice cases in which RTs are named as defendants. Proficiency takes time. We have some therapists who are now recently certified to intubate. Some of them occasionally get a heightened sense or overconfident, and then they encounter one difficult airway and their confidence is blown, and it's, can be like traumatic. And a little bit of humility and discretion is really the way to go. Practicing on mannequins, familiarize yourself with the equipment. I even say to my students, because again, I teach respiratory in addition to editing textbooks and working at the bedside, is go online, look at videos, become as familiar with the various presentations of the anatomy as you possibly can. Big tongue, small tongue, big jaw, combative patient, non-combative, and there's a lot of resources that are actually out there. The more you look and you know what to look for, the better you're going to be able to identify it when you're actually doing it. Use discretion when deciding who will intubate, experienced RT, new RT, anesthesia, attending physician, etc. And when in doubt, I say, call anesthesia if in fact you have that luxury. For the sake of completeness, we've also included some key references. For any nurses that are watching this, the Egan's Fundamentals of Respiratory Therapy, okay, is really it's a sentinel textbook in respiratory care. It's used by somewhere along the lines of about 80 to 85% of the respiratory therapy education programs throughout the world. So it's one of the textbooks that I do that I co-edit with Bob Kaczmarek, who recently passed away, and Jamie Stoller at the Cleveland Clinic. I also have a textbook entitled A Clinical Assessment of Respiratory Care, where I talk about the procedure, et cetera, how to assess, for the need for intubation and that sort of thing. And there's some other, if you will, links that I have listed here, including a link to the GlideScope company. And it's not that I'm not promoting them per se, but I say go to all of these. They have a lot of good videos, both on their equipment and just on intubation in general. So avail yourself of a lot of the information that's out there. Some of it you can even earn CEUs for, et cetera, et cetera. So with that, I hope that you enjoyed this presentation. Hopefully you've gotten something out of it, and probably a lot of it's probably just reinforcing stuff that you've learned, maybe filling in a couple of the gaps. If there's more information you want to learn about it, avail yourself of this. And most importantly, I really hope that Terry and I are really glad you came and joined us today, and we hope you come back to us again and join us for more of our continuing education series that we have out there. Thank you very much, folks, and have a wonderful day. Bye.